Good afternoon, everybody. Hope you guys had a nice lunch, and we see people are just coming in still. Let's give them a couple minutes, and then we'll start the seminar. Thanks for attending. We appreciate it. Okay, I think we'll get started. So welcome to day 2 and session 2 of our presentations. And what you're going to be witnessing today is that time for budgeting. And this is, for those institutions who are doing budgeting, this is a great chance for them to learn more about tools that could be utilized and how to interpret data. As we are going through, we're having some technical difficulties, it looks like. There it goes. This one, first, from an administrative perspective, again, a disclaimer was basically all this information is educational in nature and is not authoritative. Many of you people want CPE, and we'll get you, this qualifies for CPE. What you need to do is, I'm going to ask a question, and you need to put an answer in the question box or chat box that just shows that you are participating. And the question I ask is kind of a game too. So anybody who wants to answer the question, feel free to do so, and there's a prize will be sent to the winner. Please make sure you can send in your evaluations completed at the end of the webinar. It's important for us to know about your feedback, how things are going, and any suggestions for improvements. We truly appreciate that. If you have any technical issues, please contact Jackie A at microscopehc.com. She'll be able to get in touch with you and help you with any technical difficulties. And CPE, for those people who want CPE certifications, they will be mailed out next week. As always, there will be time for questions at the end of the presentation. And if people want copies of our presentation, just let Jackie know, and she'll be more than happy to send the information to you. So we can move to Jackie. I don't know if you can move to the next slide. That'd be good. So today's presenters, we have 3 presenters. We have Jeff Lambert. He's the CEO and founder of Organizational Intelligence. For over 25 years, Jeff has provided consulting guidance on a variety of decision support implementations and performance improvements. Jeff has the hands-on experience that people are looking for, and he's worked in the operational role in terms of systems implementation, financial reporting, and budgeting. So welcome, Jeff. We're glad you're presenting with us. And also joining Jeff is Megan Binkowski. Megan Binkowski is a CPA and a managing principal here at Microscope and leads our financial and operational performance service line. And for over 15 years, Megan has been assisting healthcare organizations with their accounting, their compliance, and advisory needs. And last but not least is Mary Catherine Buckley. She is also a CPA and a senior director in our Microscope financial and operational performance service line. Mary Catherine has over 10 years in being a CPA, assisting healthcare organizations with both their accounting, their compliance, and also their advisory needs. So welcome, all 3 of you. We're looking forward to the presentation, and I'm going to pass the baton over to Mary Catherine.
Thanks for the introduction, Bill, and thank you everyone for joining us today as we discuss budgeting. Specifically during this presentation, we will go through different budget methodologies, some hot topics related to budgeting for 2022, and then Megan will finish up our presentation with an update on the Provider Relief Fund. So as most people know, historically, hospital budgeting has been done annually with a static budget being compiled and compared to actual results on a monthly basis. For calendar year organizations, the budget process typically has started towards the end of the third quarter or beginning of the fourth quarter, with budgets being presented and approved by boards in December or January. As healthcare finance professionals know all too well, preparing the annual budget is an extremely time-consuming process. Therefore, it is paramount that healthcare organizations maximize what they're getting out of the budgeting process and evaluate the type or types of budgets that they are preparing and using throughout the year. In preparing for this presentation, we looked at several studies done surrounding budgeting in the healthcare field. We've highlighted 2 of the surveys on the slide, but all of the studies pretty consistently indicated that more healthcare organizations are starting, if they haven't already transitioned, to various types of rolling forecasting methods. Specifically on this slide, we have that a study published by HFMA in March 2021 indicates that 2 in 5 hospitals have already or are actively moving away from traditional budgeting to some type of rolling budget forecast. Another study indicates that 65% of respondents planned on adopting more agile forecasting methods this year. These and the other studies we looked at indicate that while not all healthcare organizations are moving exclusively to a rolling budget, many are at least supplementing their historical static budget process with some type of rolling forecast or analysis. Interestingly, about 43% of the respondents in the second study that we highlighted here also indicated that they believe their organization needs to streamline their overall budgeting process to react more quickly and efficiently. This shift towards this more agile forecasting and being able to adapt more quickly and efficiently was occurring prior to March 2020. But with the COVID-19 pandemic, this change has definitely sped up. Leaders in healthcare organizations should be considering if their annual budgeting process is best meeting the needs of their organization. So with that said, I'll now turn it over to Jeff to discuss budgeting and various types of budgeting methodologies.
Thank you. Try to advance the screen. Thank you. Sorry for a little technical difficulty there. As stated, my name is Jeff Lambert. I'm the COO and founder of OI. 30 plus years in healthcare finance, primarily in decision support. For those that aren't aware, OI is a comprehensive decision support tool with modules for financial management reporting, labor productivity, budgeting, both operating and strategic, as well as cost accounting and patient profitability reporting. What we're hearing from a lot of our clients, as well as the hospitals that we serve, is that they're beginning to stabilize, and there's a major refocus on the budget effort coming into the new fiscal years. There's been a lot of attention given to workplace transitions, working from home, working in the office, a lot of additional compliance reporting, as well as the extreme volume fluctuations that hospitals have been experiencing. So with that in mind, the senior management of most hospitals wants a forward-looking plan so that they can get everyone on the same page again and try to achieve various objectives. So during this budgeting process, they can establish realistic operating levels. We've seen just major fluctuations from decreased volumes, and so now that the environment is beginning to stabilize, senior management wants to again establish these operating levels. Another key part of the budget process that needs to be paid attention to again is to be able to process and monitor the objectives, review estimates versus actuals, and try to understand variances. Are these related to different volume levels, efficiencies, accounting errors, etc.? And probably the final key objective is to assign accountability to the appropriate level of decision making. So as our clients reintroduce budgeting into their financial management reporting, we see that each organization takes on this challenge uniquely. mostly depending on the resources, data, and technology that they utilize for this endeavor. Mostly all of our clients begin their process with a static budget. Others incorporate volume estimations to produce a flexible budget. Others extend timeframes by incorporating a rolling forecast, dropping off the last completed month or quarter and adding on with the next. Others extend their forecasting periods from 1 to 2 years at a time when they perform their budgeting needs. Our more sophisticated clients employ a case-based budget, where they're modeling the number of discharges or visits by a service line, payer, or location combos to estimate departmental volume levels. Virtually all of our clients employ a process to review their budget projections. Responsibility reporting allows all levels of management to dissect material variances, thus improving communication and collaboration throughout the hospitals. As with any process, there are advantages and disadvantages with each approach, so let's take a look. So starting off with the static budget. So for those implementing a static budget, the following advantages are incurred. They are easy to use and understand, and by far the easiest to implement. Static budgets do not require any regular updates during the year. Once completed and approved, the budget is complete for that period, and it allows managers to quickly understand and analyze over and under estimates for volumes, revenues, and expenses. But of course, there are some major disadvantages. The budget will not fluctuate due to any volume changes. Its key assumption is that it will remain accurate throughout the relevant range, and we know that may not entirely be true. It tends to be more focused on current data, not necessarily forecasted data, and it may be difficult to forecast new types of services since historical data is not present. But for those that are getting back into the budget season, the static budget is the starting point for any of the other budget types that we'll discuss. I think one of the key features is to have an integrated system, one where all the data flows from one module to the next. So in this example, you can see that the metrics, key performance indicators, financial information, labor information, this will all flow into the operating budget, into the budgeting tool. If you maintain separate systems for actuals reporting versus budget reportings, this requires extensive data moving, maintaining the latest data, reconciling what's in, what's out, the differences, etc. What we see then is that the budget analysts spend more time compiling the data than actually analyzing it. I like to say everyone budgets, they each budget differently year from year, and everyone takes a different approach to this process. So your budget tool needs to be flexible to be able to design the best budgeting tools for your organizations. Wizards can configure the budget module, accounting for data sources and timeframes, labor modeling, incorporating metrics and other features such as calculated accounts. So there's usually a lot of decisions when setting up the budget for the initial view. Non-financial clinical managers appreciate an integrated system because the budgeting tool has the same look and feel to how they're vetting their actual data for financials and labor productivity, as well as utilization metrics. This isn't really the first time that they're looking at this data during the budget season. The single source of truth concept is widely accepted as the best format. A key factor to any report, let alone financial, is that the users of the data trust the data. They will be more attentive to their management reports when they simply understand them better, as opposed to having to figure out all the reporting nuances. So for example, is contract or agency labor in or out of this module versus another module? Do the numbers include our new expansion projects, et cetera, et cetera? The budgeting tool also has to be easy to use for the budgeteers. This is best accomplished by providing all the information necessary to make the projections and edits. A sample setup can include a couple of years of actual data, prior year budget, actual annualized data, as well as including projected data. Selecting the natural class will allow budgeteers to drill down into specific sub-accounts. Point-and-click maneuverability enhances the user experience. This can be an appealing process compared to the learning curve required to complete, for an example, an Excel modeling process. Since labor accounts for 55 to 65% of total operating expenses, hospital organizations will want to focus the manager's time on getting the skill mix modeled correctly. The ability to look at the same data through different data slices is key. Departmental, positional, job code, employee views are key, further subtotaled by productive, non-productive, or total FTE levels. Subtotals by reg, overtime, vacation sick holiday, premium pay, down to the earning code reporting will improve modeling. The tool must have the ability to allow the hospital to model at any level that they require, either at a very high level, such as productive, non-productive, or to a very detailed level. In this example, the regular pay bucket is further modeled by regular pay, orientation, continuing education, meetings, etc. It's up to the end user as to how precise they would like to configure the budget. Transparency is one of the key goals during the budget season. Documentation is required for all budget changes. Who, when, what revised amounts, as well as the reasoning behind the change. Edits are required for all changes, either by departmental management or finance or senior management. Budget changes can also be tied to initiatives. So if you wanted to track all the changes regarding a travel account or a patient service project, you would be able to track all of those changes. Line item details can also be captured, maybe modeling the sub-account by vendor or location or project code. The ability to capture all that pertinent information in one location, this potentially eliminates the need to maintain a budget folder and saves important time during the budget season. And then the ability to quickly see all of the budget edits is informative for all levels of management. They can easily monitor all changes from all modelers in one place. So I think this was just a quick overview for, we find a lot of clients still struggle in the development of a static budget, but being able to have the right tool in place can definitely expedite the process during the budget cycle. Once the static budget has been accepted, what we see a lot of our clients is moving on into a flexible budget arrangement. So this is where they begin to incorporate more information into the budget process, such as incorporating metrics into the modeling process. This allows actual volumes to be incorporated into the modeling forecast. The flexible budget tends to be recognized as accurately reflecting current operational levels. This methodology can more quickly identify opportunities as well as mitigate risks associated with poorly performing departments. Managers may tune out the original budget entirely and try to understand how best to manipulate the flex, which can be detrimental to the overall goal. Also, this methodology requires hospitals to truly understand the causal relationships between their accounts and fluctuating volumes. Whenever additional moving parts are introduced to the budget process, it can include complex rules for one-off situations. We flex on volumes except for these departments or these sub-accounts, for this unique situation, etc. So finance must quickly realize that instituting this process can make the budget process more time-consuming. So it's no secret hospitals collect a massive amount of utilization data. Data resides everywhere. It's on the general ledger, located in data warehouses, shadow systems, all the way to being manually captured on a clipboard in someone's office. So this data needs to be collected and stored in a single database for universal review. The users, the modelers, need a complete understanding of the data sources, the data timing, any caveats to the data, as well as calculations assorted with each of the metrics. In an effort to keep the managers up to date on their metrics, there should be various displays, such as a heads-up display, where these metrics and KPIs can be analyzed routinely, preferably on a daily basis. So as I said, heads-up displays, dashboards tend to be the best way for this type of review. This puts the data in the forefront of financial management reporting. You can see here various thresholds can be set to evaluate if the metric is operating in the green, yellow, or red. Drill down capabilities are available for more detailed investigation, and these views can be designed by the individual user. So senior management may be looking at different metrics compared to maybe other department managers. One observation I've had in this process is that it's a lot easier for finance to capture the 200 plus metrics that are being kept for each department than to truly try to analyze and understand the 3 to 5 metrics that truly drive the business, that are the true business drivers for that department. Hopefully reports like this assist with this transition and really identifying what moves the department. With the flex budget, volumes will be incorporated into the modeling process. Hospitals can allow or disallow managers the ability to change volume levels within their departments. It's simply up to management if they want to grant those resources. Multiple stats can be included in the modeling process per department, not just one. So you may have labor flexing on one statistic and supplies and other fees flexing on other types. Aside from capturing the actual utilization, I feel one of the more important configurations for flexible budgeting is identifying the causal relationship between the volumes and the accounts. So we have what we've seen for our clients that have really dived deep into this process is that the mappings need to be easily configured for an iterative analysis. Being able to identify the impact of various changes is key. Rigid dimension mappings do not allow these iterative reviews and will ultimately disincentivize the management. Specific mapping should be able to be override at default mappings for specific departments. And then of course, as I said before, multiple stats can be utilized for each department, not just one. So again, the ability to map variability for each individual sub-account is critical. So in this example, drugs may be variable for one cost center or fixed for different cost centers as well. While utilizing the unit of service modeling, the focus shifts from modeling whole dollars to now modeling changes on the ratio of dollars per metric. So 2 modeling changes will affect the total dollars for each sub-account, either a change in the anticipated volume levels and or a change in the efficiency of the ratio. More or less labor supply is required for each unit produced. So a more advanced budgeting approach is the implementation of a rolling forecast. Static and unit of service budgets rely on set periods or fiscal periods or a fiscal year and create a fixed forecast for that period. Rolling forecasts, as an extension to financial budgeting, support periodic updating of budget assumptions and extend the time period out beyond the end of the fiscal year. By continuously forecasting out additional quarters, you can avoid the fiscal year cliff and give your organization a head start on next year's budget. The future is uncertain, but rolling forecasts will keep your hospital on the road to success. Rolling forecasts are extremely beneficial, especially for those hospitals that have to perpetually alter their budgets and plans to adapt to new trends. Major advantages of rolling forecasts are that hospitals can continually adapt future forecasts to reflect volume volatility, which in turn will allow them to allocate resources more optimally. The ability to tweak assumptions will allow hospitals to react more quickly. Driver-based planning, focused forecasting, efforts on the more material factors. Time-sensitive decisions are more accurately reported in a rolling forecast compared to a static budgeting approach. Unfortunately, rolling forecasts can make the finance team feel like they have a never-ending budget season. Very quickly, high-level assumptions can become complex, thus requiring more effort from finance. And finally, due to the many changing levers, it will become very difficult to perform comparative analysis. Management has to be aware of burnout when deploying this approach, both from the finance staff as well as the operational managers. When deploying a rolling forecast, technology is key. You need a system that can quickly and efficiently display iterations and their incremental impact. Many organizations find that the most difficult challenge to implementing a rolling forecast initiative is gaining organizational acceptance. Finance professionals should engage in thoughtful discussions with senior leadership for executive level buy-in, as well as departmental level acceptance. Rolling forecasting can be an effective approach for financial modeling and is flexible enough to meet a myriad of organizational structures. Rolling forecasting can increase accountability and encourages efficiency and process improvements to make organizations more cost-effective. As reimbursement sources become more fixed, it is imperative that healthcare organizations use KPI metrics to monitor the impact of cost efficiency improvements. The cultural implications of using rolling forecasting needs to be thoroughly understood and embraced by the executive leadership team, and the rollout of a rolling forecasting model needs to be methodically executed in order to be successful throughout the organization. So our most advanced methodology for forecasting includes clients that utilize case-based budgeting. Estimating the number of discharges or visits based on a user-defined roll-up structure will allow users to understand the impact on all departments within a hospital for various volume changes. Hospitals need to have implemented a comprehensive decision support cost accounting tool to complete this type of budgeting. This also transforms the budget process from a cost center sub-account review to a more patient-centric tool. Based on historical departmental charge item utilization consumption, the new case estimates will back into volume totals by department all the way down to the charge item. The cost standards developed at the product level for both variable and fixed cost behaviors will allow the budgeteers to develop pro forma income statements. Volume changes and performance improvement changes can also be incorporated into the model. Changes in gross revenue, net revenue, and inflation factors can also be modeled. So the starting point is to define the roll-up structure that allows you to model changes to. Usually this is tied to a strategic plan that senior management works on annually. Inpatient and outpatient activity is the starting level. From there, users can select different roll-up structures for each level. So for example, service lines, locations, payers, etc. One of the main goals of decision support and cost accounting is to transform financial management reporting from the historical cost center sub-account view to the patient-centric. This accomplishes that. So within service line reporting, this allows clinicians and finance to work side by side to analyze estimates of the cost of caring for groups of patients with similar conditions, the actionable cost savings from process improvement, and the benefits from better utilization of capacity. Service line management can tie the cost to patient outcome measures, which will enable it to design a system that improves the quality of outcomes, motivates efficiency and improved capacity utilization, reduces costs, and assures patients and providers that any cost improvements will not reduce the quality of care being delivered. Once the roll-up structure has been established, in this example, we're looking at inpatient Medicare patients, users can select which node in the module they would like to forecast the number of cases or visits simply by adding a % change or a new count. Historical utilization ratios can also be modeled at the departmental level. Once the model has been completed, it's very easy to understand the incremental differences between various models. Here we can ascertain the differences between a high and low model. Differences can be understood at any level in the roll-up structure. One can see which level on the node has the most impact to either caseloads, expense, and profitability. So the user here would be able to to drill down into the various levels of their roll-up structure and see the impact in the number of cases, revenues, and costs, which would be on the right. Another key report is understanding the impact to the various departments. So here's a listing of all of the various departments. Again, we're comparing the high and the low model, fixed and variable costs. And immediately I can see the difference between these two models is about a $6 million increase in expenses from the high to the low. So if I have many different models, I can easily ascertain what the impact is at the bottom line, as well as going through the various departments to understand where those changes are. Once I see some major changes, I can then drill further into the cost behavior by department. So I can see if it's labor related, supply related, or other related. So just to recap, we have our clients are on a full spectrum on how they're budgeting. We have a lot of clients that are just starting to reestablish their static budgeting, and we feel that the tool and the resources available to them will provide the most benefit. Others are now stabilizing various utilization metrics, so they're flexing their budgets. And then we have other clients that are incorporating rolling forecasts and trying to maintain a longer fiscal year or fiscal period of budgeting. And then finally, for those of our clients that have utilized the cost accounting benefits of a decision support tool, they use that patient level information for some strategic modeling at the patient level, which based upon those volumes can then be spread out by department. I think it's also key is that if you utilize a tool like this, we're trying to make this process more efficient, reduce the cycle time, not increase it. So once the budget is finalized and approved, there are many ways to push down this information from the high-level models down into the cost center sub-account budget. So this is just an example where it goes through several allocation methods and identifies if when you go to push that model down, will it reconcile? If it does, if we get all green checks, then that information is directly passed into the budget columns for the financial and labor reports, and that completes the budget cycle. I think accountability is also key for any type of budgeting tool. So what we try to do is also have our clients routinely take a look at some of the key variances that are occurring between the actual and budget amounts. This process definitely increases with responsibility reporting, management assigned to a cost center from maybe VP to the department level. This definitely improves communication and collaboration across all departments. It will highlight any accounting issues, and the idea is to improve data integrity for the next budget cycle as well as cost accounting endeavors. One of the key frustrations that we see is that if management does identify an issue and it does not get corrected, then it can get frustrating that they're continually showing the same information. Again, technology is key for this type of communication and collaboration. Here, the system administrator would simply go through an interview process and identify timeframes, what percent, and maybe a dollar materiality over, under, or both over, under, or over budget. And what is it? Is it the static budget, the flex budget, you name it. Also, we see different cultures within hospitals where maybe they want everyone to respond to all accounts and variances associated with that. Others can be just pared down to maybe controllable expenses, or maybe you're just looking at a certain supply account or labor account. So the user has the ability to provide that exact measurement. And then finally, within responsibility reporting, everyone from the management tree, from senior management to the supervisor, has the ability to explain as to why this variance is occurring. And we often find that a lot of great ideas and opportunities come about from bringing these various parties at different levels of the organization together to try to understand why these variances are occurring. Obviously, the goal here is to not only explain the variance, but also to improve the process as we go forward. So as we begin the next budget cycle or rolling forecast, that information has been properly categorized and they can move forward. So those are 4 or 5 different high-level views of budgeting, and I'll look forward to some questions after.
Oops, sorry about that transition there. Thanks for that, Jeff. Now, as Jeff indicated, there are pros and cons to any budgeting methodology used. Change is hard in general, but with a fundamental process such as budgeting, it can be extremely difficult to make a change away from static budget to these other types of budgets that Jeff went through: the static budget, the flexible budget, the rolling forecast, the case-based budgets, or even the variance analysis can require some, significant time, as it was indicated in Jeff's slides, which is why it's extremely important to find the right help in making that transition. Now, as we alluded to earlier, budgeting isn't necessarily a zero-sum game. It's not a one-size-fits-all approach. It may make sense to use some type of mix of budgets. In fact, the HFMA survey that we featured earlier also highlighted that 31% of respondents were considering adding rolling forecasts to the budgeting process. So what they're saying is that at a minimum, they're going to supplement their current processes with this rolling forecast type of budget. Now, as we said, this is a time commitment. So there are varying answers from these respondents of how long they expect to take before they can make this transition or this addition to their current process. With 53% of respondents moving towards rolling forecasts pretty quickly within 6 months, and 12% saying that it's going to take them more than 18 months before they can start to make that change. Now, Bill's going to jump back on for the highly anticipated CPE question.
Thanks, Mary Catherine. Everybody's waiting for this, I'm sure. So the friendly feud question for this seminar is name a sport shoe. I'm sorry, name a sport that requires a specific shoe. Name a sport that requires a specific shoe. Just type your answers in the chat box or the question box and you'll get CPE. And those of you who are playing the game, just put it in there and you might be a winner. Thanks, Mary Catherine.
Thanks, Bill. So some other considerations when we're talking about budgeting. Regardless of what budget methodology is being used, we kind of wanted to go through a few thoughts or tips to consider as you're budgeting. But before I get to that, I just wanted to talk about, while preparing for this presentation, as I was going through articles, I was finding articles from, 5, 10 plus years ago discussing the unpredictable nature of healthcare and how difficult this makes the budgeting process due to all of the uncertainty. So clearly this isn't a new topic of conversation, but in, the more recent articles even, and based on what I'm seeing within the industry, the pandemic has definitely exacerbated this difficulty. So not to sound like a broken record, but budgeting for healthcare is hard, and even in normal circumstances, and it's even, even harder now that we are dealing with COVID. So, some tips and thoughts that are relevant no matter what, what situation we're in, but are especially relevant now given this current status of the healthcare industry and the world at large. So this first item is the conservatism in your budget. Budgeting is typically done on a historical information plus basis, meaning that actual statistics for volumes and actual expenses incurred are gathered, and then tweaks are made to adjust for current and projected changes. However, with the continued uncertainty surrounding the COVID-19 pandemic, historical trends aren't necessarily going to be as useful as they typically are. Realistically, we have pretty limited data, and it's not clear yet how certain industry trends are going to continue to shake out. Therefore, it may be more beneficial to be more conservative in your modeling for volume recovery And on the expense side, it may make more sense to budget for costs to continue to increase. And we will get into some of these considerations as we continue with this presentation. But another thought was the importance of budget flexibility, which Jeff definitely already alluded to, and that budget flexibility during these continuing uncertain times is important, especially given the huge pressure on healthcare systems brought on by the COVID-19 pandemic. This is where the budget process needs to go beyond the finance function, in that flexibility and productivity and staffing is currently paramount. So your volumes are always variable. Always. So if you're in the Northeast, think back to past flu seasons when you've had to flex staffing based on, a particularly bad strain of the flu. But being able to see this in more real time, where volumes are currently and where these volumes are trending, will give facilities an opportunity to better manage staffing, which is going to be, continue to be important as we get through this, Delta variant and whatever is coming next with COVID. It's also important to get buy-in on the budgeting process from outside of the finance department and make it a collaborative process. From what I've read and people I've talked to, there can be a considerable amount of time in many organizations spent negotiating with departments about how much they're able to spend in the next year, how many FTEs they can have. Well, instead of making it contentious, it's important to be focused on overall strategic planning and trying to get as many stakeholders as possible involved early in the process to make it a more collaborative process, so that again the overall strategic goals of the organization can be set in a coherent manner. Kind of the final overall thought here is the evaluation of current healthcare trends and how important it is in the budgeting process to consider both local and macro trends. So to say that differently, what's happening both in your facility and outside of your facility. So especially given the nature of the current pandemic, it's going to be important to holistically look at all of these trends for better budgeting. I'm going to start by going through some expense trends in the next couple of slides. So salaries and benefits are obviously typically a significant expense for healthcare facilities. So we're going to start by looking at some factors surrounding staffing that should be considered in the current budgeting process. The first is changes made to mandates surrounding regulatory staffing levels. So there's no federal standards that currently exist, with California being currently the only state in the country required by law to have specific nurse staffing ratios. For example, the California law requires hospitals provide 1 nurse for every 2 patients in intensive care and 1 nurse for every 4 patients in the emergency room. Other states do have some more general guidance, but California is the only one currently that has such specific staffing requirements. And the reason why I'm bringing that up here is that in June 2021, New York State implemented new staffing requirements for both hospitals and nursing homes. So hospitals are now required to form clinical staffing committees, of which at least half of the members must be frontline nurses and other direct care staff. This committee is required to have input into setting annual staffing standards for units. And then the staffing data will be required to be publicly available. Nursing home facilities will be required to meet a minimum daily average of 3.5 hours of nursing care per resident. And the Department of Health is, planning some enforcement in that the staffing plans be implemented with potential monetary fines if not. So, some information is still getting fleshed out in these details, but this is out there and is, expected to in some way impact budgeting and staffing levels. And one of the things that makes healthcare finance difficult is that patient care is, most important. And everything can't necessarily be driven by the bottom line as it can in other industries. As staffing levels are correlated to good patient care and patient satisfaction, getting these staffing levels right is important both for positive patient experiences and on the finance side for any potential incentive-based payment agreements that you are in. So, still kind of unclear as to a monetary impact that these staffing changes related to this New York State law will have, but this is kind of bringing you to, know your facility and look at your facility and be asking yourself, what are your current staffing requirements that you've set internally? How do you expect these to change? How is the finance department going to be involved in this clinical staffing committee? Just keeping all of this in mind as you are developing your budget in the next year. The next significant industry trend I wanted to discuss is the hot topic of the current and evolving vaccine mandates. So as pretty much everybody on this call is aware, I'm sure, there is both a federal and a state vaccine mandate currently. The federal vaccine mandate is coming through as a mandate for healthcare workers to the Medicaid and Medicare conditions of participation, with certified facilities required to have their employees vaccinated by October 2021. And the New York State mandate is that all hospital and nursing homes receive their first dose of vaccines for their employees by, by next week, actually. Now, there are still some court cases open relating to these vaccine mandates, but if these mandates are enforced, many facilities will be negatively impacted from a staffing perspective. It's what's being projected currently. Given the significant amount of vaccine hesitancy, there's obviously concern on retaining and being able to hire enough staff to properly staff hospitals, nursing homes, and other healthcare facilities. Even, it's making the local news, even here in Syracuse, that a couple weeks ago, a hospital was going to, it was in the news that a hospital was going to have to stop delivering babies in the near term due to the number of maternity workers resigning over this COVID vaccine mandate. So this is real. It will affect potentially your volumes and your revenue if units can't be staffed. So it's going to be important to look at where your staffing levels are, where different clinical staff can be moved to, all considered as part of your budgeting process. And with these changes in the staffing mandate levels and this vaccine mandate, it's the contract workers are going to continue to be a significant variable in many hospital budgets. So contract workers have, in the rates that they get paid, have been, considerable topic in the past couple of years. But given with the pandemic, the overall cost of hiring these workers has increased. On top of the staffing difficulties with what we've talked about here, as well as burnout from the pandemic in general, there's probably going to be a increased need for contract workers if you can find them. So that should be considered by talking to the staffing agencies you use, figuring out what the projected cost is going to be, as well as internally figuring out, can we avoid using the contract workers, or are we going to have to use them as we continue going through our budgeting process. So some other expense considerations outside of hospital staffing. And sorry, I am losing my voice, so just bear with me for 1 second here. Thanks. So outside of staffing, there are some other factors impacting your expense budgeting. So your PPE requirements, obviously during 2020 and 2021, there have been significant expenses related to your personal protective equipment by many healthcare facilities. It's expected that these expenses will continue, given there are still PPE requirements at various government levels, as well as the continued ongoing pandemic. The worldwide supply chain distributions are currently, they're everywhere. They're in the news, talking about the current supply chain disruptions that are causing increased lead times and increased prices. I actually just read a couple articles in the Wall Street Journal yesterday and today on various worldwide supply chain matters. What really stuck out to me was that shipping rates are increasing, with the Wall Street Journal reporting that spot container shipping rates from Asia to the US West Coast are 14 times higher than in 2019 at the same time. With experts not expecting to see material improvements in 2022 to either shipping costs or shipping delays, but are expecting shipping costs and timelines to normalize by 2023. So, you know, outside of the healthcare world, but still definitely potentially could be an impact on your supplies and equipment costs, given that these increased shipping rates have to get passed on somewhere. There's also the continued well-documented concern around inflation driving prices up. And another consideration here is the increased labor costs through both increased minimum wages and tight labor markets, with that cost potentially being passed on to healthcare facilities through both the supply and service contracts. And I mean, the minimum wage increase, looking at that, I know some facilities have actually increased the minimum wage that they are going to be paying their employees based on the tight labor market, increasing that to the $15 mark or higher in some cases. So definitely, you know, looking at that, and if you have a flexible budgeting process, it's going to be easier to implement those changes. All right, so now that we've kind of gone through some staffing, some expense considerations, on the revenue side, obviously the two overarching items to consider are going to be your volumes and your rates. In terms of the volumes, clearly we have the resurgence of COVID and the continuing uncertainty surrounding those volumes. You know, looking at local data and just projecting the best that you can, it's very difficult to do, especially, you know, sitting here today trying to predict volumes for the next year is going to be extremely difficult to do. And unfortunately, there's really not much out there in terms of what should be being done. So again, it's going to be about knowing your facility and looking at local data. Other impact on volumes is telehealth. Several facilities had, you know, some significant revenue gains in the telehealth space, which is great. But the current reimbursement by Medicare is only through the end of calendar year 2021, with CMS proposing to extend that expiration date through September 31st, 2023, under the current proposals that are out there that are not yet approved yet. Which brings us into a discussion on rates, with most of the calendar year 2022 hospital rates and physician rates still being in draft form and not finalized yet. But one significant kind of global theme is that the suspension of the 2% Medicare sequestration is scheduled to end at the end of this year. So you should be expecting, at least currently, a 2% reduction on your Medicare payments, similar to how it was back in 2019. Last piece here is, you know, the common know your contracts. How is your telehealth going to be reimbursed? What are your rates doing? Make sure that you have the correct people with knowledge of the contracts included in the budgeting process. So if the past 18 months have really shown us anything, it's the need to be able to prepare strategically to react to government mandates. Healthcare, we know that rates are always in question. And you know, there's been several new funding opportunities in the past year. With perhaps the most significant of this being the Provider Relief Fund, which Megan is now going to be giving us an update on.
Thanks, Mary Catherine. Oops. So why are we talking about provider relief funds, right, when we're talking about the budgeting process? You know, I know much of this was impacted into 2020, so in 2021. So going forward, why are we considering this? And really, the reason for that is as Mary Catherine and Jeff kind of alluded to before, was the need to shift from the static budget to a flexible budget in order to remain strategic during these times, right? So We already discussed the significant impacts of volume fluctuations and increased costs related to labor and supplies, but that other big change that occurred with the onset of the pandemic was that relief funding that came through to help offset those costs. While the provider relief funds and other COVID funding sources that were offered through CARES and the American Rescue Plan really were a welcome relief to many healthcare providers who really needed that infusion of cash to even continue to fight that pandemic. There was the constant changes to the reporting requirements, the changes to the deadlines of the reporting, the changes to the use of the funds, the different definitions of eligibility depending on what funding source you were reviewing. It's really presented a significant challenge to those that are on the front line and a huge administrative burden. That trend towards rolling forecasts that we've been discussing, I know is a very time-intensive process, but we've really found that those organizations that had already started to shift towards that trend and implementing that process, the ability to remain flexible and update their budget and their projections have really been better poised to remain strategic with this influx of funding that's come out over the last year and a half, and able to ensure that they're in compliance with these ever-changing regulations, and yet still quickly respond to new funding opportunities that continue to be presented without putting the funds that you had already received at risk. So what you are reporting now can really impact what you're going to be able to apply for in the future. So have you simply completed a calculation to fulfill your reporting needs, check that compliance box, or have you really truly assessed the impact COVID has had on your organization and gone through all of your expenses, come up with a true lost revenue calculation, and then project that into the future, how you expect to estimate that and apply for these funding sources in the future. So this first slide here is really just a quick summary of the distributions, so the past, so the ones that have already been made from that provider relief fund, which was signed into law as part of the CARES Act on March 27th, 2020. I won't go through all the detail of these payments and how they were determined. I'm sure most of you know the funding that you received since that first reporting window is quickly coming up. But one thing we did find that many organizations knew that they got money and came from the provider relief fund, but didn't necessarily know which tranche of money it came from. So we have each of the distributions here, and there are timelines available to show you about when the distribution dates came out. And each distribution really had its own unique set of terms and conditions that you had to attest to. So it is important, especially when you're coming back to these nursing home infection control targeted distributions and the nursing home quality incentive targeted distributions, as they have some unique qualifications compared to the other reportings. This next slide here, this chart is directly from that Hersa provider relief reporting website. It summarizes the reporting requirements and the deadlines to utilize the funds, which is based on the date that you actually received the payment. So this first reporting window, as I'm sure you're aware, ends next week, Thursday, September 30th. And it really does account for a majority of the funds that were released under the provider relief fund. All the general distributions 1 and 2, and then most of the targeted distributions really did occur prior to that June 30th, 2020 cutoff date. There was a 60-day grace period that was recently issued for this first reporting window, but HHS did specifically state that the deadline to use the funds and the reporting time period really did not change. That 60-day grace period is just for enforcement, so they will not initiate any collection activities during that 60-day grace period. So this chart that's included here was issued in June when the final reporting guidelines were issued by HHS. And once these were issued, the AHA actually issued some letters, and we're fighting on behalf of the healthcare organizations to try to get additional time to report and spend the funds. There shouldn't really be an end date. It should just be when the pandemic comes to the end. They did issue this letter, which indicated that the uncertainty in the federal rules has really hindered many of the providers' abilities to use the fund within the allotted timeframes, and that these 4 different deadlines are going to be confusing to administer and disproportionately impact some providers more than others. The letter continued to give examples about how many hospitals delayed specific projects while we were waiting for clarification in the federal rules. And specifically, they indicated that Hersa issued unique terms and conditions for each payment and updated their frequently asked questions related to the PRF 32 times between May 2020 and June 11th, 2021. And then I don't know if you all have been keeping up on the FAQs, the 75 pages of them that are out there, but they updated them numerous times after this June 11th, 2021 release. Some as recent as September 13th, so just last week. So it is important to continue to check back with those. So it was not until June 11th that many providers learned that you had these 4 buckets to spend the money within. Only gave you about 2 weeks to be able to be strategic and turn around and use those funds from that first tranche of money. Hopefully your organization had the information available to you to assess the most recent rules and truly understand the impact and how much of your funding would be covered by revenue loss versus qualified expenses. I'm not going to go into detail on the reporting requirements because at this point, I assume most of you have been through them, have started the reporting process, I hope, or maybe some of you have already completed your submission. But for those of you who have not completely submitted, I do urge you to go back to this order of reporting and to review this and take into consideration what you were reporting in this window and how it's going to impact both your future PRF reporting windows as well as these other opportunities that continue to arise. So the order, again, for the reporting is first, you're going to report on the use of the infection control and quality distributions. Again, note these 2 had some unique terms and conditions in that you are not allowed to report revenue loss to account for those funds. And there's some specific allowable expenses related to infection control that need to be utilized. The next round would be on qualifying expenses, which are to prevent, prepare for, and respond to COVID-19. Again, the focus here is expenses that another source has not reimbursed or is not obligated to reimburse. So you may still be pursuing some of your expenses to be funded from other sources, and those would not be included here. For these qualifying expenses, the theme from the beginning has really been the same, even though there's been some changes to the regulations, but overall, the key premise has really been no double dipping between the various funding sources. So after you report on the infection control and quality, qualifying expenses, the last category is really that lost revenue. And again, there's those 3 options that are defined there of calculating that lost revenue, and you're going to be reporting on 2020 and the first 2 quarters of 2021. So this slide here summarizes some of the other funding opportunities that were already made available over the last 1.5 years. I'm not going to go through all of these. Many of these programs have already come and gone, so aren't available for current funding, such as like the Paycheck Protection Program. But really, I wanted to highlight these as they are going to come about to make sure you're not double dipping in what you're submitting for this reporting window. So the first ones I want to highlight here are those 3rd and 4th items, which relate to the reimbursement of actual COVID patient claims and testing. Note that if you receive reimbursement from either the uninsured program that was available through Hersa or from other payers such as Medicare or Medicaid for a COVID patient or testing or vaccination, then the only portion you can submit under PRF is the portion that your costs were not covered by those payments from those other payers. Excuse me, sorry. Also important to note, I'm sorry, reimbursement from these other payers or from the uninsured program are two categories that will not be reported under the other assistance category of that reporting portal. So you don't have to report the revenue or the expenses, but you do need to make sure you're considering them and not double dipping in what you're entering for your expenses. The next group of funding to highlight relates more to the payroll and benefit costs for programs such as the Payroll Protection Program and the Employee Retention Credit that were available. These programs, like the others, had many changes to the regulations and availability, whether you're an affiliate and what that meant. Also, initially, you could not participate in both programs, but then under the Consolidated Appropriations Act, it changed and you could utilize both programs as long as you were not utilizing the same qualifying wages. Again, so that's providing multiple categories that can cover payroll costs, whether it be the PPP program, ERC, FEMA, which is also listed here, and the provider relief funds also have certain qualifying payroll costs or employee retention credits. So you really need to go back and really assess where did it make sense to most apply those funds, where can you get the best reimbursement from it, and what specific categories of payroll benefits and retention costs can be picked up by each program. The last one on the list here is that FEMA Public Assistance Program. So in the beginning of 2021, there was the increase in the federal cost share for this program. Initially, it was at that 75% of reimbursement, and they increased it to 100% for qualifying costs. FEMA indicated that they simplified the process for providing public assistance under this disaster, but I'm sure any of you who have either been through the process or started the process think it is anything but simplified. It is a long process. And a lot of detail is required. The end date for this emergency has not yet been announced. FEMA indicated they would provide at least 30 days notice before establishing a new deadline, but continue to monitor the Department of Homeland Security and Emergency Services website and talk to your local Department of Homeland Security rep. So FEMA, same thing with HHS, has placed a heavy reliance on not double dipping and how they would work together. I know there was a lot of back and forth in the beginning about who was technically the payer of last resort. And so that might have held up the process of applying for FEMA in the beginning. And many people have been working through what would be a FEMA qualifying expense versus a PRF qualifying expense in these last few weeks. And hopefully you can have the information available. You were able to update those budgets and projections to determine what strategically to report under HHS versus FEMA. So now that we have talked about the funding opportunities from the past and how you're going to report on those, this slide covers some of the more recent updates and future potential funding, but again, need to consider what you're reporting on for the past so that you can kind of optimize these funding opportunities that we have included here. I think it was almost 2 weeks ago now, HHS had the announcement for this next round of provider relief funds. So under phase 4, there's about $17 billion available. In addition to that, under the American Rescue Plan, there was $8.5 billion made available. The $8.5 billion is targeted for certain specific rural areas as defined by the Federal Office of Rural Health Policy. There's actually a website you can go in and type in your hospital's address to see if you would qualify under there. But the application for these funds is expected to be available on September 29th. It's one application for both. And it's going to be based on your revenues, your lost revenues and expenditures between July 1st, 2020 and March 2021. So again, what's impacted from the past is going to potentially impact the future payments you can get here. So more to come once that application is available next week, the day before your first reporting is due. In that same announcement, they indicated that providers who believe their PRF phase 3 payment was not calculated correctly, they can now have the opportunity to request a reconsideration of that payment amount. And then the last one I highlighted here was the USDA Emergency Rural Healthcare Grant Program, which will be due or available depending on which track of funding you're looking at on October 12th, so coming up. So this program really focuses on rural, again, organizations that are located in an area with 20,000 residents or less as determined by the latest US Census data. So again, potential funding in the same theme between both this USDA and the most recent PRF is going to be a real focus on those rural healthcare providers. So that is all we have for today. Thanks for joining us. I think we have some time left, so I'll send it back to Jackie for any questions you may have, as well as the response to the Family Feud question.
Good afternoon, everyone. Jackie Almoran here, and I handle the marketing for Microscope. Thanks everyone for joining. We did get a lot of answers from people from Bill's question on name a sport that requires specific shoes. I will go ahead. We actually have the top 8 answers on the board here. So I will start with number 8, that is baseball. Then coming in at 7, we have wrestling. Number 6 is football. Number 5 is basketball. Number 4 is track. Number 3 is golf. Number 2 is soccer. And number 1 is bowling, which probably only like 3 or 4 people guessed. So that was a fun little thing. We do have a few questions here. Just give me a moment while I pull them up. Question number 1. What is the process for reconsideration of my phase 3 distribution?
So I have a partial answer, I guess, for that question. Hersa is really still kind of developing that process of how you're going to submit reconsideration applications. So more to come on that. They did issue kind of the formula that they used for the initial payment. So I urge you to go back and take a look at that recalculation now, because they did say once they release how they're going to do that almost appeal process, it's really going to be subject to whatever funds are left. So I think it makes sense now for you to go back to that calculation. There is a formula that's out there. Take a look at what they did, because it was supposed to be the greater of, I think it was 88% of losses, which is a formula based on Q1 and Q2 of 2019 and 2020 data of revenue loss, less change in expenses, or either the greater of that or 2% of the annual patient care revenue. But that was based on the most recent tax filings that you had available. So depending on what year of data that you ended up submitting in your application, you might want to recalculate that. They then took the greater of that payment and reduced it by any other PRF funds you had already received to come up with a payment amount. They did have some adjustments to those payments. They said risk mitigation, cost containment. If what you submitted in your application seems to be an outlier, depending on the type of provider that you had, they did apply some sort of reduction to your initial payment. So if you do recalculate that payment now, it should be in the next week or 2 that we hear more of how to appeal that.
Great. Looks like we have a few here for Jeff. What is the typical time frame required to prep the budget module for modeling?
Yeah, I think that's a great question. We get that quite often. As discussed, if they treat their decision support tool as a single source of truth, where managers are vetting financial information, labor, as well as their KPIs, what we see is instead of having to create a budget tool over several weeks up to a month, and utilizing the wizard tool, we see that a lot of our users in an afternoon, 1, 2, 3 hours, can enable the budgeting tool and have it ready to start budgeting. Also, as our clients progress from static budget to flex budgets to rolling forecast, if they're utilizing maybe a homegrown tool or Excel spreadsheets, then that would require complete reconfiguration for the new budgeting methodology. So you definitely want to select a tool that can transition you as you go through various methodologies. So static budgets, 1 to 2 hours, and then as you go forward, you need a tool that can transition with you.
Great. I think this might have kind of been addressed, but can I frequently change my budgeting methodologies?
Yes, I think during the presentation I said everyone budgets, they all budget differently, and they like to change their methodologies year from year. So we do anticipate those changing methodologies. And again, not only your data and the resources required to configure the budget process, but you definitely need technology that can keep up to date as you progress and get more precise.
Okay, question just came in. In the time for the modeling tool setup, what did that mean? That the directors or managers help to populate it?
No, this would be, so all the information flows directly from other modules, and so there's no need to load additional data. The setup time is really on finance and how they want to set up the budget season for the various department line managers. So department managers really have no setup, and as I said, they appreciate the process because the budget tool has the same look and feel as how they're looking at their financial information, labor productivity, as well as some of the key drivers in their department. Now they're just utilizing that information to budget for the upcoming fiscal year. So it's really time spent on the finance side as to the exercise they want managers going through to develop a budget.
Okay. Last question here. What do you consider the best method to forecast?
Well, again, I think the obvious question is that nobody truly understands the future. Everyone who gives their best estimate, they're off. But I think if you have a tool that is flexible and nimble enough to be able to handle and calculate changes in volatility, performance improvement initiatives, and everything else, that's probably the best situation. So for those clients that have gotten to case-based budgeting, what we see is that the estimates are tied to a strategic plan. Those get pushed down to the department managers, and the managers then are just necessarily making small minor changes to supply levels or maybe the level of care, etc. And so we've heard that it could reduce 2 to 4 months out of the budget cycle because it already ties to a strategic plan. And usually what we hear often is that there's still $2-3 million bottom line variances, where budgeting then becomes who's the best negotiator, as opposed to maybe a budget based on standards. So for those clients that can get to case-based budgeting, we would recommend that as being the best approach.
Terrific. That concludes all the questions that we have live right now. I do welcome everyone to jot down anyone's email address if you have any further questions that you might think of later on. And at this point, I'm going to send it over to Bill Blair from OI Health.
Thank you, Jackie. I'm the CEO of Organizational Intelligence. I wanted to let you know we're very excited about the unique Microscope and OI partnership. It's providing Microscope with the tools required to maximize your entity's performance. And as a software vendor, the relationship provides our customers with world-class consulting services that will be specific to you and will maximize utilization, financial reporting, budgeting, and even cost accounting. Our common goal is that you spend your time and efforts analyzing data and not just gathering data. And as Jeff said, all the data is already there to populate for budgeting. So I hope you enjoyed the webinar. I hope it was beneficial to you. And I want to thank you for joining us today.
Great, thank you, Bill. And Bill, thank you so much for working with us. We enjoy our partnership with OI Health, and we hope that we can introduce you to many clients. And I know they'll get a lot out of OI Health and the strategic analysis out there. So, and very much a thank you for everybody who attended and those who presented, Jeff, Megan, and Mary Catherine. So thank you so much for presenting. I thought it was a great session. And again, if you have any questions, the contact information is down below. If you want the handouts, ask Jackie for the handouts, and she will send those to you. So tomorrow's Wednesday, and being the third day of the week, we decided to have 3 programs. Educational sessions to start first thing in the morning at 10 o'clock Eastern time. That's really regarding cybersecurity, financial and fraud risk, and that starts at 10 o'clock. Our second program on Wednesday talks about leases. A lot of people have not implemented the leasing standard yet. We're going to talk about, the time is now. It's really no more extensions on that. So hopefully you can make that. That's at 1:30. Again, these are all Eastern Standard Time. And then our third session on Wednesday really talks about the revenue cycle, internal controls. Are they functioning? And that's going to be a great session on, really the internal controls and how that potential non-functioning could actually impact the dollars you're not receiving at your organizations, or maybe dollars you have to pay back, unfortunately. So we hope you can attend, and thank you so much for attending today. Have a good evening. Take care.